Any of that on tape. Like, I did go to college, okay? Not my thing, but I did try it. All right. Now, health assessment techniques, we are going to inspect first, of course, palpate. We do need to palpate the chest, okay? We will continue with that with cardiovascular as well, because you're going to look to see, or palpate for any heaving, or you'll even palpate for a PMI, okay? Percussion. In lab yesterday we learned that percussion is tapping on the back of your fingers. So if I'm going to be percussing Shauna's posterior thoracic area, I'm going to put my finger in between the bones, or the rib that's there, because you don't really want to percuss bones, because it's just going to be dull anyway. But we want to, no offense, your bones are dull, get it. All right, but we want to do this, and it's much better, and granted she's wearing kind of a thick sweatshirt, so it's kind of really hard to hear. You want to do it directly on skin, and what you should hear is a nice hollow sound. Why would we want a hollow sound with the lungs? Because they should be full of air. If you hear a dullness, that means there's either fluid in the lungs or you're on a bone, because it's not going to have that vibration, okay? And then finally, we're going to auscultate. Now, this thing changed on me by itself a second. All right, we're all familiar that the lungs do the exchange of oxygen for carbon dioxide. Very important role in maintaining what's called an acid-base base. Okay, or balance, excuse me. Acid-base balance. I'm okay. It's your hearing when it's wrong. All right. Come up next semester, I believe, in semester 6. You guys will learn how to interpret arterial blood gases. And so you need to be familiar with that. Yes, ABGs, okay? You have to know what the pH is, what the bicarb is, all those fun things, okay? Let's see. Big thing too, the right lung has 3 lobes, left lung has 2. You do need to be familiar with that. Okay, from the front it's easier to see. On the back it looks like there's just 2 on each side. All right, speaking of, ta-da! Now, in lab yesterday I had a complete brain fart, and I could not for the life of me remember 2 of the 3 expected breath sounds. Group 1, do you guys remember what those 3 were? What are they?
And then no one knows.
Right? They're like, oh yeah. That was me yesterday going into class. And I was like, duh. Not tracheal, bronchial, bronchovesicular, and vesicular. Okay? Those are your 3 expected lung sounds that you need to be familiar with. We will go into some what are called adventitious breath sounds tomorrow, which are your unexpected ones. Okay.
You said vesicular, bronchovesicular, and what was that one?
Bronchial.
Then bronchial.
Yeah, it goes going from here down. It goes bronchial, bronchovesicular, vesicular.
Okay.
Okay. So, and this is just the posterior angle of the chest here. All right. Now, keep in mind, a lot of the physiology of the lungs comes into play when you're auscultating, believe it or not, okay? Because depending on what's going on, more specifically with these little grape-like structures, believe it or not, you can hear when these are congested, okay? You hear it, and for you ladies, it's gonna be easier for you, but if you take your hair and just kind of run it between your fingers back and forth, you'll hear like a little crunch, 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 right? Like, do it! No, just kidding. I see some people going, oh my God. But that little crunchy sound, okay, that's what crackles sounds like in somebody's lungs. That means that the lungs are wet, either from pulmonary edema, so that excess fluid in the body goes somewhere. If they're not peeing it out, it goes to the lungs typically, all right? Or each of these little ones could be filled with sputum or mucus of some kind. So then you might get fine or coarse crackles. All right, you have to know the difference, okay? What's one of the ways that's non-pharmacological to help somebody breathe a little bit better if they've got thickened liquids or thickened fluids in their lungs? That's one, but physiologically speaking, not just changing their position. One thing when you're sick, what do we always tell you to do? Huh? Cough. Yeah. Oh, thank you. Drink more fluids, right? Because the more fluids that somebody drinks, the thinner those secretions that are in their lungs will be, and it'll make it easier for them to cough them up. Okay? And also, kind of going back to that IS thing, when they take deep breaths, even if they're in there for pneumonia already, they can still be doing those IS exercises, because then it'll help these to reinflate by getting the air in and any mucus or inflammation and stuff out, and then that's called pulmonary toileting, because then they're coughing it and flushing out the bad stuff, getting rid of it, taking it out of the system. That's why I really am just absolutely disgusted when people are like, they'll cough up stuff and they go, phew, and I'm like, whoa. Okay. Now, a couple of definitions here that you really need to be very familiar with and comfortable with, okay? Ventilation, that is the actual exchange of oxygen for CO2 and CO2 for oxygen within the lungs, okay? Diffusion is when it goes between the alveoli and the red blood cells. So when it goes from being a deoxygenated red blood cell to an oxygenated one. Then we have perfusion, and that is when it goes to the tissues. All right. So right now we've got it going right here for at the air sac within the alveoli, but now it's getting to the tissues, and then that is perfusion. Has anybody here ever seen a liver? Well, you did at least an A&P. Okay, what did it look like? What color was it?
Like a brown red.
Like a maroonish, right? Really more on the red side probably, okay? Have you ever seen a liver with absolutely no blood in it?
Like black.
It's not really a gray, it's not black either. It's actually more this tone because it's just tissue, the filtering tissue of the liver. What makes it red is all the blood that's going through that and being filtered, okay? So if we aren't perfusing the liver, it's not going to work. So that's the whole purpose. That's my best way to kind of get you to understand perfusion, okay? It has to go through there, be filtered, get any toxins out, all that fun stuff, okay? Now, when it comes to respiratory, as far as changes within the older adult, we're going to have a decreased amount of surface area within the lungs. All right? We don't really think about it that much because we're like, well, we have lungs, okay? But over time, and if they've abused their lungs, or you know, they worked with chemicals out in the field or anything like that, our air here. Have you guys ever come in from like Sedona and seen the absolute disgusting brown haze that just hangs over Phoenix?
Yes.
It's disgusting.
Yes, LA was horrible.
Oh, LA is even worse.
Oh, LA, I'm like, oh my God, yes.
Yeah, LA is even worse.
You don't even have to go
Okay.
that high. You just go to the observatory and then you can see.
You could probably go to the top of that mountain right across the way there and be like, damn. Okay, it's disgusting. Okay, but we don't see it because we're here within it and we're breathing in all that toxins and stuff. Okay, so think about that in another, well, for most of you, 20, 30 years, what that's going to do to your lungs. Okay, we're going to have a decrease in breathing and the respiratory rate and the lung capacity. Okay, your lungs can only fill up so much, right? Everyone's a little bit different based off of their size, all right? And as you get older and those tissues atrophy and everything, that's going to get less and less. So your respiratory rate should probably, to compensate, is probably going to do what? It's going to go up. Okay, our bodies like what's called hemostasis. We like it likes a nice even amount of oxygenation going through its entire body, and if it doesn't do that, or if it's not getting that, it compensates. All right. Decreased dead space, that's the amount of air that's kind of left within the lungs. It's not moving back and forth. All right, that will come into play specifically with emphysema. Because what happens with emphysema, those nice little air sacs in the lungs, they're pretty elastic. They open and close with the air movement just like balloons, okay? But what happens with emphysema is instead of those opening and closing, or enlarging and getting smaller and allowing for that oxygenation to happen, they are just like an old balloon that just stays in a certain shape. Doesn't have that elasticity anymore. So then the oxygen can't move in and out of that alveoli, and it basically is dead space. It's not having any function anymore. Decreased vital capacity, that's the overall size of the lungs itself. The cilia become an ineffective ally in removing dust and everything from the respiratory system. So along the inner bronchioles here and throughout the lungs, we have cilia that kind of helps bring things towards the main bronchus so that we can cough them up. Again, with age, it's not moving as much. They're like, you're fine. They're not like, hey, come on, get out. Gotta get evicted, okay? Kyphosis, that's that nice little curvature at the upper part of the spine. What's it called when it's down here? Lordosis, okay? All right. So when you first come into a patient's room, one, don't panic. Okay, you'll be fine. But if you have a patient that looks like this, what's one of the first things you could kind of ascertain from this gentleman? Does he look comfortable?
No.
He's in a tripod. He's got his hands on his knees. Okay. What else? He's on oxygen. Does he look well nourished? No. He's probably utilizing more energy to keep breathing. His respiratory rate's probably elevated too because of it. Even though we've got him on oxygen, so that way he doesn't have to breathe as much, his heart is still having to pump that oxygenated blood around to those tissues that are asking for more and more, okay? So we can get the respiratory rate, the efforts. One of the things that you guys will be asked too is, how is your patient breathing? Not like the respiratory rate or the rhythm or anything, but the work of breathing is going to come into play, okay? I'm sure everybody here at one point has seen somebody out on a field or a track or something, and they're just like, they are working to get the air in, right? You can see what's called their accessory muscles. Their neck is even trying to come into play, and you can see this area right here, the tendons and everything, trying to get air into those lungs as fast and as much as possible, okay? That's what we're talking about when we talk about accessory muscle use. All right. Their color, it's a little bit difficult for people of a darker skin tone to assess their color. Okay. Where would we look? Their conjunctiva. Okay. Now, if we're just coming from interacting from the hallway to see this gentleman in his room, okay. Upon general survey, where could we look?
Palms of the hand.
Palms of the hand first, okay? So, diaphoretic can happen again because they are working to breathe, and then the client's position, orthopnic position. This is important. You'll run into this too later on in peds, because I'm sure anybody here who has kids has seen at the playground when they get out of breath, what do kids typically do? They squat down like this. That's just a natural instinct to tripod. Okay. The orthopnic position that we can also use in the hospitals, we can have the overbed table in front of the patient and have them lean forward and go like this. And it just opens up the bases of the lungs back here a little bit more so they can get a little bit more oxygen moving through. Okay. Some subjective data to be familiar with. Do they have a cough? And if they do, is it productive or non-productive? Meaning, are they getting anything up with it? And if they are, what do you think else we need to find out? Coca! Color, odor, consistency, and amount. Okay? Now this is why this is my kryptonite. I hate sputum. It's the most disgusting, most vile thing. you will have people cough up stuff that you're just like, damn, what died in your lungs? Because it just absolutely reeks, especially if they're smokers. Okay? Have they been having any problems with being an SOB? And I do not mean son of a, what do you think I mean?
Short of breath.
Biscuit.
Shortness of breath. Son of a biscuit, yes. Whoever said that, good call. All right. Do they have any allergies? That's another big one, especially for people who have asthma. They need to know what their triggers are. Because asthma is what's called a RAD. It's not the coolest thing, but it's a RAD, in that it's a reactive airway disease. It has to have some type of stimulus to cause the body to respond to it. Okay. Typically what happens is the airway gets inflamed because everything's going there. It gets smaller, makes it harder for the person to breathe, okay? And sometimes they might have mucus buildup in that area, which again makes it even smaller. And so if they know what their triggers are, we can help avoid it. Another reason why we should not be wearing a whole lot of perfume or scented creams and lotions as healthcare workers. Because you could quite literally send someone into anaphylaxis. Okay. Are they having any chest pain? Why would we be worried about chest pain in someone with respiratory issues? Say it loudly. Don't. As he gets lower. Why would we worry about chest pain with somebody with respiratory issues? Yes, Kevin.
I think maybe like the pleural space could be.
That's one of them. Okay.
Cardiac.
Remember, we've got the chest cavity itself, then we have the pleural space, which is a micronism of fluid that lubricates the outer portion of the lungs, and then we have the lungs, right? There could be a buildup of fluid in there that can cause pain and discomfort, or even difficulty breathing, because that's taking up space where the lungs would be. Okay, that's one. What else?
Inflamed bronchial tubes.
Pardon?
Inflamed bronchial.
Inflamed bronchial tubes? Yeah, if anything's swollen, it's gonna hurt, right? Could be related to pneumonia.
I guess maybe more obvious answer would probably be like a lack of oxygen to the heart would cause
What is that called?
a type of heart attack. But
nope.
ischemia is probably the term they're looking for.
I'm looking for pulmonary embolism. That's a
Oh.
blood clot to the heart or to the lungs. An embolism, okay? And if they're having a hard time breathing and they're having chest pain right here and it's not cardiac related, they probably have a blood clot right there that's causing them difficulty, okay? All right. Then we want to know any history of respiratory infections. Other than pneumonia, what else could it be?
TB.
Could be TB. I already gave you a couple answers.
Pertussis.
Pertussis would be for kids, yeah. Still applicable, okay.
Do for bloating, you can do cystic fibrosis. What's it called?
For bloating?
Yeah, it's like sorry, cystic fibrosis is that one?
It's not necessarily an infection. They tend to excrete more mucus in their lungs, and because it's so thick, they have a harder time coughing it up. And so we have to do physiotherapy to help loosen it up. But it's not really an infection, but it does, I see where you're going with that, okay? So we want to have a history of, see if they have a history, of asthma, COPD, pneumonia, or this lovely guy. Bronchitis is another type of respiratory infection. Yes, ma'am?
Would valley fever be one?
I wouldn't call, it's more of like a, what is it, it's a fungal infection, but yeah. Yeah. You guys know where valley fever comes from, speaking of which?
Spores in the soil.
Spores in the soil. In the soil? In the soil. That's why anytime you guys go by any type of construction work, what are they doing? Well, hopefully they're working, But what are they doing with the dirt?
They're putting water
They're
on
keeping it wet so that way it's not stirring up any possible spores within the soil. All right. Now, a couple other questions. Do you sit up when you breathe? And do you sleep with multiple pillows? Now, I sleep with 4 pillows, but they're not all behind me, okay? I have 2 behind my head, 1 here, and 1 right here between my knees. That's my 4 pillows, okay? So you would have to clarify with your patient, you know, if they say, oh, I sleep with 6 pillows, where are they located when you're sleeping with them? Because that's gonna make a difference. Because they might have 6 pillows, and they're sitting up to breathe, but they have, you know, they're sleeping like this. Whereas, you know, if they're sleeping with 6 pillows, they might have 1 back here, 1 between their knee, 1 underneath their elbow, 1 in here, you know, all the fun different things. Okay? So, let's see. Any smoking history? Now, cigarettes are the big one. Okay, but now here in Arizona, we have another type of smoke that is legal to be imbibed.
Jazz cabbage.
You get the devil's lettuce, okay? Mary Jane, if you want. We need to know that as well. Even if they're doing hookah with non-tobacco products, the fact that they are imbibing smoke into their lungs is going to cause an issue, okay? I would even venture to say, even if it's not necessarily smoking, but even just, what's it called? The chew. You know, it's not necessarily going to cause direct respiratory problems, but it can cause a lot of mouth issues. I have seen patients who have had their entire jaw removed from abusing chewing tobacco because of cancer within their jaw and everything else. So that's definitely going to be an issue for breathing, because now they have an open spot right here where they can't really protect their own airway. Okay. Then of course, occupation and environmental exposure. We talked about the housekeepers. Okay, they breathe in and exposed to all types of chemicals out there. You know, and even just walking past certain certain businesses and stuff, you're gonna get exposed. I mean, we even have this sign out in front of Jimmy John's that says free smells, right? Now that's a good one. But there's still other things that we could be exposed to that we can't smell, we can't see. Okay, anybody know of any other of a type of gas that we could be exposed to that we can't smell or see? Carbon monoxide. So we have those lovely carbon monoxide detectors for homes now. We'll make sure that they're up to date on their immunizations for flu and pneumonia. And if they've had a recent x-ray of their chest, do they know what the results look like? Okay. We, in ICU, we do chest x-rays on our intubated patients every day to determine if that tube in their airway has moved up or down or anything like that, if they're having any chance of what's called ventilator-associated pneumonia. So we as healthcare workers would have access to look at those as well, okay? We're gonna wanna get a full set of vital signs. Now what do you guys see here? Got John Doe, heart rate.
76.
Okay. Now we know it's an adult. All right, so is that a good heart rate?
Yeah.
Okay. Respiratory. We got a respiratory rate of 18. Is that expected? Yeah. What's the expected range?
12 to 20.
12 to 20. All right, then we have a blood pressure over here. Hypertensive?
No.
Pre-textbook, pre-hypertension, because we're above the 120 over 80, but we're close enough to where I would say they're not hypertensive. All right, now what about this?
Very low.
Very low. So what do you think we need to do for this person? Are they compensating yet?
No.
No. Why? What would you expect them to be doing? Higher respiratory rate and the heart rate. Okay. Now, this is what's called a waveform, and this is a little advanced for semester 5, but I just wanted to address that. This is a good waveform because it's nice and consistent. But if this was all over the place and you still had these regular, within range vital signs, okay, what would you think was going on? Say it again? The cord might be malfunctioning or it might be off their finger, okay? Because this goes along with the heart rate. Do you notice that? All right. So if this was all over the place, then this may not be an adequate reading of it. Or what if I told you that this person was perfectly fine, but their hemoglobin was low? Would that make a difference?
Yeah, because hemoglobin carries oxygen.
Right there. Okay, so if his hemoglobin's low, then that's probably going to be inaccurate as well. Okay?